Welcome to the deep dive. You've brought us a set of revision notes, and today we're taking a deep dive into chronic rhinosinusitis, or CRS.
That's it.
Think of this as us unpacking those notes together, sort of pulling out the really essential knowledge you need and, well, making it stick.
Exactly right. These notes, they cover all the crucial bits of CRS, from what it actually is to how it's managed. Our goal is to walk through this with you, highlighting the high-yield stuff in a more conversational way.
Yeah, turning that structured data into something maybe a bit easier to digest for revision, or even just getting up to speed quickly. So whether you're, hitting the books hard or maybe just curious about this condition, which is really common, actually we're going to be your guides through these specific notes.
We'll follow the flow they've got, but yeah, add that conversational layer, hopefully make the key facts pop a bit more.
Okay, let's dive in. The absolute core first.
Yeah.
The definition. What exactly are we talking about when we say chronic rhinosinusitis?
Okay, right. So the fundamental thing, according to these notes, is prolonged inflammation. It's in the nasal cavities and the sinus cavities.
And that word prolonged is key, isn't it? This isn't just like a quick cold.
No, absolutely not. And that's where the really crucial diagnostic point comes in, the detail that makes it chronic. The notes really stress this. For it to be CRS, the symptoms must last for more than 12 weeks.
12 weeks, okay.
Yeah, that duration, that's the bright line. It separates the chronic stuff from, more acute problems.
So we're talking persistent symptoms, ongoing inflammation, affecting the lining, that mucosa inside the nose and the sinuses.
Exactly. Inflammation that just doesn't clear up after that typical sort of acute phase.
And it's surprisingly common, you mentioned.
Yeah, the notes highlight this right away. It affects up to 1 in 10 people, which is, well, it's a lot.
1 in 10. Wow. Okay, so definitely something you're likely to encounter.
For sure, which leads nicely into the epidemiology, like where we see it most.
And the notes focus on the UK.
Yeah, they specify the UK context, saying it's common here, and they repeat that figure, roughly 10% of the UK population.
Okay. And there was something about age, too.
More prevalent in adults than in children. Just simple facts, but it helps build the picture.
Right. Okay, so why do people get this? Let's talk etiology, the causes, the triggers.
Well, the notes are pretty upfront that the exact cause isn't always fully understood. It could be multifactorial,
Okay.
But they list several key contributors. Infections are mentioned, bacterial or maybe fungal sometimes.
Allergies seem like a big one, too.
Definitely. Makes sense, right? Structural issues inside the nose are listed.
Like a deviated septum, maybe? Though the notes just say structural abnormalities.
Yeah, it could be that. Nasal polyps are mentioned here as well. And then broader things like immune system disorders and environmental factors.
Things like air pollution, cigarette smoke, that kind of thing.
Exactly. So it's often not just one single thing triggering it, more like a complex mix.
Which connects to the risk factors, I suppose. The things that make someone more likely to get CRS.
Precisely. Things that create that susceptibility.
Yeah.
And you see overlap here. A history of recurrent acute sinusitis is a big one. Makes sense, right? Repeated acute episodes could become chronic.
Yeah, definitely. Nasal polyps again. Allergies and asthma are listed again, too.
Immune system disorders, those structural abnormalities, again, reinforcing their role. And exposure to environmental irritants like that cigarette smoke we just mentioned.
The notes also had this section on predisposing factors. Look like a lot of overlap, though. A phytotopy.
Right. Atopy, which is basically that underlying tendency towards allergic conditions like hay fever or asthma.
Okay.
So having that predisposition maybe combined with, say, a recent local infection like a bad cold, rhinitis, or even a dental extraction near the sinuses.
Okay. Or things like swimming, diving, smoking again.
Yeah. It feels like these factors kind of prime the system, make it vulnerable. Then maybe an infection or an irritant just tips it over the edge into that chronic inflammation state.
Like they build on each other, creating a sort of perfect storm.
That's a really good way to put it, yeah. They compromise the body's natural defenses, the drainage mechanisms, which leads us perfectly into the pathophysiology, the how, what's actually happening inside the sinuses.
It all comes down to inflammation, doesn't it? The notes say the central process is this persistent inflammation of the nasal and sinus mucosa, that lining.
And that inflammation, as we've said, gets triggered or kept going by all those factors: infections, allergies, immune issues, irritants. But here's the real crunch point. The inflammation makes the lining swell up.
Okay.
And makes it produce way more mucus.
Right, and that swelling and extra mucus, that causes the big problem with drainage.
Exactly. The sinuses have these little openings, the ostea, that normally let mucus drain out and air circulate. When that lining is all swollen and clogged with thick mucus, those openings get blocked or narrowed right down,
Ah,
and the notes are clear. This impaired sinus drainage is the absolute core issue. It causes the ongoing symptoms and makes the sinuses vulnerable to getting infected again and again because stuff just gets trapped in there.
it sounds like a vicious cycle. Inflammation blocks drainage, traps stuff, causes more inflammation.
Precisely the kind of cycle you see in chronic conditions. It just feeds itself.
So if someone comes in with symptoms, could be CRS, but what else might it be? The differential diagnosis.
Yeah, super important. What looks like CRS, but isn't. The biggest one the notes flag is acute sinusitis.
And the key difference there is just time, right?
Absolutely. Acute is short-term. Chronic is more than 12 weeks. That time frame is your number one clue.
Okay. What else is on the list?
Allergic rhinitis,
Yeah.
hay fever, causes congestion, discharge. But it's more about the nasal passages themselves, not necessarily that deep chronic inflammation within the sinuses like CRS, although allergies can definitely contribute to CRS.
Right. It also mentions nasal polyps themselves, which we said could be a cause or complication too.
Yeah, exactly. They can be the main issue causing blockage, or they can arise because of the CRS inflammation. Also, nasal septal deviation, that structural issue again, causing obstruction.
And then just a general other causes of nasal obstruction.
Right. The key takeaway, especially for revision, is always ask, has it been going on for more than 12 weeks? And is there evidence suggesting inflammation in the sinuses, not just the nose? Helps narrow things down.
Okay. Makes sense. Let's get to what someone actually feels. The clinical features, signs, and symptoms.
Right. This is what brings people in. The big ones listed are nasal congestion, that blocked up feeling.
Yep.
Facial pain or pressure is really key.
And there's that specific detail the notes mention, the one that often comes up.
Ah, yes. The pain is typically frontal, sort of forehead or cheeks, and it characteristically gets worse when bending forward.
The bending forward thing, that's a classic. Why does that happen?
Just increases the pressure inside those inflamed sinuses. It's a really useful clinical pointer.
Good one to remember. What else?
A reduced sense of smell, anosmia or hyposmia. The inflammation messes with the olfactory area. And nasal discharge, or that feeling of postnasal drip down the back of your throat.
And the notes had a useful point about the type of discharge.
Usually clear if it's more driven by allergies or vasomotor issues, basically blood vessel reactivity.
Yeah.
But it gets thicker, more purulent, kind of yellowish or greenish if there's a secondary bacterial infection kicking off on top of the chronic inflammation.
So the color can be a clue, though the underlying CRS isn't always bacterial.
Exactly. Headaches are common too, usually linked to the pressure. The notes also list a few others people might get. Cough, often from that postnasal drip irritating things.
Fatigue. Makes sense with chronic inflammation.
Yeah, definitely. Dental pain, sometimes referred pain from the maxillary sinuses right above the upper teeth roots. And even bad breath sometimes.
And the notes connect the dots too, like nasal obstruction leading to mouth breathing.
Right. And the postnasal drip causing a chronic cough. So the impact goes beyond just the nose itself. It really can affect quality of life quite significantly.
Okay, so given all those symptoms, how do you actually confirm it's CRS? What investigations do the notes mention?
Right. The notes are really clear on the primary method, and this is important. Diagnosis relies heavily on the clinical history and symptoms. What the patient tells you, the duration, the type of symptoms, that's number one. Plus a physical examination looking inside the nose.
So you don't automatically jump to, like, CT scans?
Not usually as the first step for diagnosis, no. According to this material, imaging studies like CT or sometimes MRI might be used, but often later. More to assess how extensive the inflammation is, or look for those structural issues or polyps you might suspect. They're more confirmatory or for planning treatment, rather than the initial diagnostic tool in most cases.
Okay. And nasal endoscopy was mentioned too.
Yes, that's another useful tool. Lets you get a camera right up there for a direct look at the nasal passages and the sinus openings. Helps spot inflammation or blockages. But again, the diagnosis really starts with listening and examining.
Got it. History first. So, diagnosis made, what's the plan? How is CRS managed according to these notes? What are the goals?
The main goals, in the UK context these notes focus on, are reducing that inflammation, controlling the symptoms to improve quality of life, and crucially, improving sinus drainage, tackling that core mechanism we talked about.
And the treatments listed seem quite varied. From simple stuff like saline
Yeah,
irrigation.
just flushing out the nasal passages with salt water.
Yeah.
Simple, but can be really helpful for clearing mucus and irritants. Then, topical nasal corticosteroids are a real cornerstone.
The nasal sprays.
Exactly, delivering anti-inflammatory medication right where it's needed. Oral corticosteroids pills might be used for short bursts during bad flare-ups as they're stronger.
And antibiotics.
They're on the list, but with a really important if. Typically only used if there's clear evidence of a secondary bacterial infection. Not usually for the underlying chronic inflammation itself, unless bacteria are proving to be driving it.
That's a key distinction. What else?
Antihistamines, especially if allergies are playing a part. And then, if medical treatments aren't working well enough, or if it's very severe, surgical interventions are an option.
Like that FESS procedure, functional endoscopic sinus surgery.
Precisely. Using an endoscope to go in, enlarge the sinus openings, remove blockages like polyps or thickened tissue, directly tackling that drainage problem.
Makes sense. The notes also had a bit specifically on managing recurrent or chronic sinusitis, which seemed to reinforce the main points.
Yeah, it listed avoiding allergens, using those intranasal corticosteroids regularly, and doing the saline rinses, basically highlighting these as key ongoing sort of maintenance strategies.
Okay, so it sounds like it often needs a long-term combined approach. Now, super important, the notes highlighted red flag symptoms in the management section. What are the warning signs we absolutely need to look out for?
Yes, vital for safety. 3 main red flags listed here. First, unilateral symptoms, meaning all the symptoms, the blockage, the pain, the discharge are only on one side of the face or nose.
And why is just one side such a red flag?
Because typical CRS inflammation tends to affect both sides, maybe unevenly, but usually bilaterally. Strictly one-sided symptoms could suggest something else entirely, potentially more serious like a tumor or a fungal ball or a really localized aggressive infection. Needs urgent checking.
Okay, wow, big one. What's number 2?
Persistent symptoms despite 3 months of compliant treatment. So the patient's been doing everything right, using the sprays, the rinses, or whatever was prescribed for 3 solid months, and they're just not getting better.
Meaning the treatment's failed? Or maybe it's not CRS after all.
Exactly. Or maybe a complication has developed.
Yeah.
It signals that the current plan isn't working and needs a rethink. Maybe imaging now, maybe referral to a specialist is needed.
Okay. And the third red flag?
Epistaxis, which is just the medical term for nosebleeds.
Right.
Now, minor nosebleeds happen, but persistent or significant nosebleeds cropping up alongside these chronic sinus symptoms. That's another sign that needs investigation to rule out other causes. Again, things like polyps or potentially more concerning growths.
Got it. So the 3 red flags, one-sided symptoms, treatment failure after 3 compliant months, and significant nosebleeds. Crucial to remember.
Absolutely crucial.
Okay, finally then, prognosis and complications. What's the general outlook and what can go wrong if it's not managed well?
Prognosis-wise, the notes are actually fairly positive. With the right management, consistently applied, most people can get good symptom control and improve their quality of life. But
There's always a but with chronic stuff.
yeah. They immediately add that it is a chronic condition, meaning it often needs long-term management. It's not usually something you cure completely and walk away from.
Right, it's about managing it over time.
Yeah.
And complications.
Well, recurrent sinus infections are listed, which makes sense given the drainage issues. More seriously, but less commonly, thankfully, is the spread of infection to nearby structures.
Like the eyes, or even...
Potentially the eyes, causing orbital cellulitis, or very rarely, spreading towards the brain, causing things like meningitis or abscesses. That's why those red flags and proper management are so important, to catch things before they get anywhere near that stage.
Wow, okay. That really underscores it.
And finally, the development of nasal polyps is listed as a complication, which is interesting because we saw polyps as a potential cause or risk factor too.
So they can contribute to CRS, and CRS can lead to more polyps? Another one of those cycles?
Seems so. Really highlights the complex, sort of interconnected nature of it all and how it can progress if it's not kept under control.
Okay, wow. We have definitely covered a lot of ground there, straight from those revision notes. From the basic definition and just how common CRS is, through the tangle of causes and how it messes up sinus function, to the symptoms, diagnosis, management strategies, and those really critical red flags.
Yeah, we've tried to pull out those core details and string them together conversationally. You know, thinking about its chronic nature, all those different contributing factors, the fact that management is often long-term. What does this deep dive tell us, maybe, about the importance of approaching CRS with, well, patience and persistence, both for the person experiencing it and the clinician managing it.
That's a great point. It's not a quick fix, is it? It's more about ongoing management, understanding triggers, staying on top of symptoms.
Exactly. It needs that holistic, long-term view.
Well, we really hope this deep dive has helped clarify chronic rhinosinusitis for you and maybe made some of that key information a bit more memorable for your revision.
And just a reminder, if you are navigating medical revision, you might find some useful resources over at pathomsra.com and also freemsra.com.
Thanks for joining us on this deep dive into chronic rhinosinusitis.